So let's hear about it. Let's hear about your experience over 20 years. Let's hear about the people that you have and have not intubated. And then let's tie that into the evidence. And I might not change your mind today, and that's fine with me. But at least we've had a dialogue in a group full of people who now are hearing both sides of the story. And I'm respecting that other side of the story. And they can make their own decisions. And that's part of my job as the educator is to present the evidence in a way that hopefully people accept it and want to move forward in an evidence based way. So I always like those questions of, I disagree. That's not the way I think my practice should be. That's fine. I'm not going to change everyone's mind overnight, and I should never have that idea. But it's that respectful, just a respectful conversation, and using that as a different way to present evidence. But going back to your point of you got to know it three times more. If you don't know how to convey that evidence in a respectful way that relates to that person's lived experience, that draws all those connections at one time. Yeah. I can't spell. That's my worst thing is that, I'm live in a digital age but I'm very analog in my teaching style. I like to use a whiteboard, but I tell them like I have no forgiveness for the number of spelling mistakes I'm going to make over the next 3.5 hours.
But even just the appreciation of I'm talking, I'm writing on this board, and I'm trying to describe it in a way that you comprehend it easily. Like there's multiple different pathways going on.
Yeah. Yeah, now I don't care as much, but I early in my career, there'd be times where I would be teaching and writing, and, one's not following the other, and I'm writing the whole wrong thing, and someone be like, "Hey, I think you did that completely wrong." And then you don't know where to go from there. Now I'm like,
Yes.
"You 100% I did." I'm like, "Hope you didn't write it down." Uh, as you're erasing it, but it's a lot. It's a lot to manage at one time, but that's part of the shtick is, yeah, you're juggling 3 balls while, singing their favorite tune. It makes a difference is that's what's engaging, to people is that you have multiple streams of things going on at once that everyone can be focusing on something that works for them.
That's such a good point because we will mess up. We're fallible and students will call you on it. How would you deal with that respectfully besides just owning it? Like, is there ways because you can see people naturally get defensive.
Yeah. Yeah, I mean, and this takes time, I think it would be ignorant for me to say, like, just don't care. Um, some of the best advice I ever got in teaching was not to take anything personally. So, after 10 years, making a mistake doesn't bother me. It rolls right off my shoulders. I actually appreciate when someone points it out because that tells me I've made them feel comfortable enough that they can, say, "Hey, I think you did something wrong." Um, I think the other thing that can be harder sometimes is when someone might have bias or they might have the totally wrong idea. Um, and they're trying to present a point that is not factual or not based on good evidence. And then you can kind of get in this argument where then that person might get a little bit defensive. So again, it's finding that way to make that human connection, make people feel comfortable where they too will say, okay, I got it. Maybe I am making a mistake. So it goes both ways. A lot of times when people have a confrontational student, and that leads to escalation. It's not that that person wanted to escalate the problem. It's that the comfort level wasn't there for us to resolve it amicably. So I've found, since really trying to get to know my students and being mindful of who I have in the classroom, really don't have any real behavioral concerns in that classroom because we're working on mutual respect. And even when things could get heated or we might not agree, we're doing that in a respectful way, and that takes time. So I think that's the key is that, I have to spend that time, and what I find early on is I need to pick my battles. So if I don't know the person really well yet, then I probably don't wanna get into one of those things that could be really confrontational. So part of it is just get to know people, and then you can have harder conversations, and they don't feel so hard.
I think that goes back to your point when it's connecting and knowing that if they're having emotional conversation, you're trying to have a reasonable, objective one, it's not going to jive. So you got to be able to read that person and know that person. And then that could lead to like the backfire effect. It's like, oh, well, you're telling me this, so I'm going to tell you this evidence, but they just doubled down and I doubled down on my
Yeah.
stance.
Yeah. Yeah. We see that all the time in CME, right? I mean, intubation is the big one right now. I'm an ACP. I love to intubate, and a lot of ACPs love to intubate. A lot of ACPs went to school at a time where intubation is the gold standard in airway management. But as we know, if I miss my first pass on my intubation, the patient's likely to have more negative outcomes, and we have good alternatives to intubation. We got an iGel that's available. But what can be hard is now I'm telling someone something different than what they've learned for years. So automatically I've created dissonance because they feel like, well, you're telling me what I've done for the last 20 years is wrong. And that I can appreciate. I can appreciate how that would feel for someone to stand up there and say, what you've done for 25 years is wrong. So it's holding the floor to say that things change. So, not saying that your practice is wrong, but this is kind of where we're headed and why. And then allowing people to have their perspective. So, someone puts their hand up and says, "I disagree." Great. This is gonna be good for both of us because we can have an open dialogue. I can respect your point of view, and I can always respect someone's anecdotal evidence from their career. So that 25 years, they've experienced a very unified subset of the population that's unique to them, maybe not, generalizable to the entire public. So let's hear about it. Let's hear about your experience over 20 years. Let's hear about the people that you have and have not intubated. And then let's tie that into the evidence. And I might not change your mind today, and that's fine with me. But at least we've had a dialogue in a group full of people who now are hearing both sides of the story. And I'm respecting that other side of the story. And they can make their own decisions. And that's part of my job as the educator is to present the evidence in a way that hopefully people accept it and want to move forward in an evidence based way. So I always like those questions of, I disagree. That's not the way I think my practice should be. That's fine. I'm not gonna change everyone's mind overnight, and I should never have that idea, but it's that just a respectful conversation and using that as a different way to present evidence. But going back to your point of you gotta know 3 times more, if you don't know how to convey that evidence in a respectful way that relates to that person's lived experience, that, draws all those connections at one time, like you said, it's a lot of work. You're doing a lot of mental math in a moment because you don't know what someone's gonna say or what they're gonna ask. And that's where I think people can struggle sometimes and that's where educating can be super uncomfortable. If people ask something or put you on a spot and you have to try and meet them where they are, but also if you have a goal, try to meet that goal.
And that just shows that you are trying to connect because you're essentially saying it's like, listen, we may not agree, but I'm trying to understand where you're coming from because maybe I can change my view as well. And I want to hear what you think because you've experienced all this. And so just saying, no, you're wrong, because that's not going to do anything. That's not going to be productive.
Yeah, and almost always you're on the same page. Like what I've always find interesting about those conversations is when you don't give the conversation space, then you don't actually know what the person was asking. So you shut it down and you move on and you're not really sure where you're at. So I always like to give it space because then they provide context. So usually the person's like, "Well, I had a call when," and then they give you the patient specifics and the contextual information, and you're like, "Well, I totally agree in that situation." You know, the context is always relevant. So I always like giving time for that. And I mean, it's kind of selfish because now I've just done a case study in the middle of a class and I didn't have to make the case study. So, um, it works and it helps kinda bring people around, and I always like those ones because you watch people nodding. Like, you watch people like, the person's talking, and you're kinda going back and forth, and people as long as it's not totally crazy, then usually people are nodding, and, they're like, "Okay, yeah, that makes more sense," and we've just checked that box of what we're trying to accomplish even probably stronger. And people like to watch a little confrontation, you know? You get a good you get a good dialogue going, people enjoy a debate. So, like I said, it's free it's almost free entertainment or free engagement for me in order to teach a little bit better.
And everyone loves their stories and anecdotes. And we know in the grand scheme of things, it's limited quality evidence. Like you can never hold an anecdote, but anecdotes are powerful and they're really hard to change people's minds, like you said. And when you get the context, everything, it's like, yeah, I can appreciate what you're seeing and feeling at this moment afterwards.
100%. I think the best example of that is what we talk about with, right now experiencing things like PCI denials. So people know we know what the evidence is. We know when a STEMI patient needs to go to PCI. We are super good. You look at our rates, our medics are doing a fantastic job at recognizing out of hospital STEMI. They know when someone's having a heart attack and when they need to go to PCI. So you've got someone who knows they know the pathophysiology, they know the management plan, they got the ALS and BLS down, they've got the diagnostic recognition down. They know exactly what they're doing. You give them 10 STEMI cases, they'll identify all of them and tell you that that patient needs to go to PCI. They have one instance where they talk to a physician on the phone maybe who says, "Yeah, I don't think so. Take him to the closest." Maybe they get into a little bit of back and forth. They're trying to advocate for their patient and they get immediately shut down. You took someone who was 100% confident, and one single event has now changed their entire practice, and their confidence level goes down. Maybe they are unlikely to take a very similar patient to PCI because of the emotional connection. We can't downplay that. Like those types of events are like canon events or your core memories, right? Like they are very important events that can fundamentally change practice. So I love hearing about them because they've clearly been impactful. If I remember, the 90-year-old I intubated 15 years ago, there's a reason for that. And, again, for me to just say, "No, you're wrong, move on." Well, there's a lot more to that than just that single case.
Dr. Taylor Bishop, she's part of the like education subcommittee for the prompt, amazing physician. She told me a study where physicians called for other physicians to help got shut down. They were affected by that for 10 years on average after, and they were reluctant to call for help again just from that experience.
And I think that's such a good point to relay out there. As an ACP, I can think of times maybe I've been called for pain management or maybe I'm called for ACP backup. And I don't think about, or I do, but maybe I'm not thinking about how my behavior impacts that person. And I think that's such a good lesson for all of us when I'm handing over in the emerge, when I'm handing over at Sunnybrook, when Orange is coming to take my patient on scene, when I've been called for ACV backup, those interactions will influence future practice if they're negative, and they will influence future practice if they're positive.
How do we maintain the positive relationships then?
I mean, it's so funny because the connection is always there to education, is that it's just about relationship building. We want to treat people like human beings. So, remembering that that's a person in front of us. We're not just, cogs in the wheel of medicine. We're all human beings with lives, and remembering that piece I think is critical. If that's not enough, if looking at the human in front of you is not enough to treat them like they're a human, I think remembering that it's about the patient and it's not just about this patient, it's about the next one and the next one and the next one. And recognizing that my behavior has a ripple effect on all the other patients, I think is wild. We talk a lot about that a lot in ACP school about leadership and positive leadership and making people feel comfortable, and that your interaction on this call is going to influence future calls, and influence how that person treats other people on other calls. And we don't think about that. We all think that we have minimal impact. In reality, we have a ton of impact. I'm sure that PCI doc who denies, the one medic at 3 a.m. doesn't think that I might influence the lives of 10 STEMI patients over the next 10 years, but we know they will. Uh, and the evidence tells us that they will. So,
Dr. Adam Pyle, when he was on, he told like residents and like paramedics that if you do a tough call, tough patient, you always have to worry about the next patient you see because you're still heightened. You still maybe not focus, and you got to remember to be in that moment and realize this is someone brand new and they deserve respect because they aren't human, but you may not be ready to do that yet, which is difficult from everyone's side.
oh yeah, I mean, there would be a ton of science behind that. Even remember when I was in university and they talked about a study where they put someone at the edge of a cliff. So the person's standing at like the edge of a cliff looking down. So they're innately anxious and they've got increased cortisol and all those types of things. Um, so then they make the person be introduced to someone new. Um, uh, and almost everyone said I was attracted to that person, regardless. Like, so they would look after and say, "Would you be attracted to this person?" They're like, "No, absolutely not." Um, so again, it's the situation changes my cognition. and then changes the way that I interact day to day. So 100%, like, you do a really hot call or something that has your cortisol level up, has your stress levels up, and then you go on to the next call, you might be more likely to interpret someone's behavior differently, to interpret symptoms differently, and interact differently because you're interpreting what you're feeling inside and applying it to your environment, which sometimes is not the case. I agree, and I think that probably speaks to the need to have decompression following calls. The ability to get back to net zero before we start going out there again.
And that can connect to being a student in a classroom and also being a teacher. Like, imagine you have a rough day, kids are being not that nice to you, and you have to get up there and present and perform and connect. And the inverse to that, is imagine the paramedics coming to see me, they're having rough times and they have to listen, engage, and deal with everything. And just taking that time, even if like maybe a minor conflict's happening, thinking like, why are they acting this way? Is this just a stress response? What's going on and trying to understand has really helped kind of mitigate any conflicts that I've found. Do you have any
Yeah.
suggestions on that?
Yeah, and I think, I think if you walk into those types of situation with the understanding that very few people are going to purposely interact in a negative way. Most people have positive intentions. It's often situational that leads to people behaving in a certain way. Uh, I know the days that I leave here, maybe I had a hard time getting the kids to school, didn't sleep enough. I'm only one espresso in instead of three. Um, and I get into a classroom and a student shows up 5 minutes late, which I traditionally don't care about. And I feel my blood pressure go up a little bit as they walk in late. That's not about them. That normally wouldn't bother me. That's about me and the things I have going on. So again, like you said, if that's the case with me, then that can be the case for everyone else. So just to like meeting people where they're at and, say someone is confrontational, usually get to next break. I'm like, hey, you all right? Like anything going on? Anything I can help with? Depending how well I know them, I'll try to connect with them. Uh, because like I said, the majority of people do not have nefarious intent. Or maybe I don't know their experience with education. That's the other big piece I find teaching CMEs, especially to students that are coming in maybe twice a year rather than weekly, is you don't know what their experience has been like in education. Maybe they've had instructors who have treated them like garbage for the entirety of their education, or they've had really, fairly traumatic or bad experiences with educators. Of course, they're going to apply that to me. So I need to earn some trust before uh, I start, get digging deeper. So sometimes when someone like, they sometimes they'll come off a little heated. It's my job to let it roll off my back, manage my classroom, then know I need how I need to manage it, keep rolling with the educational goals, and show them that I can be trusted, and that I'm not going to be a negative educator.
We've seen that too, where people's body language, because that's a huge part of teaching too. You got to read the room in more ways than one. And sometimes it just takes that time just to like, hey, you can trust me. I want to help you. Let me know how I can help you. Let's get through this together instead of just doubling down and be like, because people again want to be educated. If they've
Yeah.
had negative experiences, it may take a bit longer to get them into it.
Absolutely. Yeah. Absolutely. Especially, you had negative experience with education, and maybe you've also had negative experiences with the content that we're delivering. So now I've got someone who has two pieces of stress involved in the education. Uh, but again, we like to take it personally. And it's so easy to say, don't take it personally. But again, 99.9% of the time, it is not personal. And if we could take us or take our ego out of it, it would be better for everyone.
And just the medics that open up to gaining and fostering that trust, being able to learn and ask questions openly, it's like that's mean the world to me. And just seeing their reaction and like their shoulders drop and everything is astounding to watch and just have that comfort there.